the spotlight for you?
Yeah.
Yeah. Okay. Thank you. Thank you. Good afternoon, everybody. Welcome. Warm welcome from Coloplast, and thank you for joining our webinar this afternoon. We'll wait a few minutes whilst everybody's joining in. I know it's 1 o'clock. We'll just wait for a minute, but to get us going and test our IT skills and connections, it'll be great to say if you can say hi and let us know where you're actually located currently. So this webinar is published nationally within the UK, so it'll be good to know where you're from. And if you are dialing from abroad, hopefully not, because I don't think this goes abroad. Well, welcome everybody. So don't be shy and say hi. Oh, Katrina's already got her hand up. Hopefully, Katrina, did you want to speak? Let me see whether I can
allow Katrina's mic. So
okay, you do that, Kirstie. And when we start, I'll introduce everybody else.
Hello.
So, oh, hi, Katrina. Are you okay?
Katrina.
Hi. I'm currently work for NHSP as an agency nurse, but I do quite a lot of shifts at Tenbury Community Hospital.
Yeah. Welcome. Absolutely fine. Thank you for joining.
Thank you.
Okay. Thank you. Right.
So we've got quite a people that have come into the chat. We've got Reading, Worcestershire, Jersey,
Jersey. Welcome.
Essex. Where else?
Did I see Melbourne?
Norfolk, Hampshire, North Wales, Birmingham, Shropshire.
Durham. I can see Durham.
I've got 3 from up my neck of the woods in Gateshead. You're just a little bit further north than me. Helensburgh,
Hertfordshire,
Glasgow.
I can see, and Manchester.
Yeah,
Glasgow.
Cumbria.
Okay.
Yeah. Berkshire. Yeah, so we're stretching far and wide.
Fantastic. Right. Let's begin. So good afternoon, everybody. As I said earlier, warm welcome to all of you. So this is the Meet the Coroners Court webinar on pressure ulcers. So my name is Rommel and I am one of the Tissue Viability Nurses from Coloplast, and I am joined by my colleague here, Kirstie Atkinson, who will be delivering half of the session. She'll introduce herself formally later. And we're also joined by Charlie Lay. She will be helping us with the chat. I can see you all are very engaged already, so that's a good start. So we are indeed having a good start. So just a little bit of housekeeping. So if you're not on mute, just make sure that your mic is on mute, just to prevent any unwanted background noises. And as we started this webinar, we highly encourage your participation via the chat. That would be fantastic. Following the webinar, we will send you out a certificate and also a copy of the recording of the session. That will be sent to you by Ben, who is also here to support that from a technical perspective. And throughout the session, and I think we will post any additional information if you need any further knowledge to increase your CPD, particularly if you're due to revalidate. So let me start the session. So we hope to finish at, am I correct? No, it's 1 o'clock, at 3 o'clock, hopefully. Am I correct, Kirstie?
Yeah, 3 o'clock.
Thank you. 3 o'clock. So we've run this webinar this morning with quite a bit of technical difficulty. But hopefully this time we will be absolutely fine and there's no technical issues. So I'm just about to share my slides as I will start the webinar. So I will begin the session on the importance of documentation, and then we'll go to simplification of care using the Coloplast 3-step approach. That will take me about 45 minutes to hopefully an hour. We'll have a break at around 1 o'clock for about 10 minutes to relieve your pressure.
2 o'clock.
Get a cup of tea.
2 o'clock, Rommel.
2 o'clock, sorry. What did I say, 1?
1. We'll have a break now.
It's been 1 of the, we are starting at 1. Thank you, Kirstie. 2 o'clock, hopefully we'll have a break. 10-minute break there, and then Kirstie will run the Coroners Court simulation. So let's begin. The importance of documentation. Now, you probably will think, not a very exciting topic, Rommel, to start with. No, maybe not. are absolutely important when we talk about delivery of care. Documentation is an important aspect on what we do, particularly clinically, to protect our patients, to protect us, and to protect the organization that we work for. Now, you will hear me keep repeating that again. So there's some sort of advantage of repeating it again, so that we get that learnings really into place, because that's what we're trying to do today. Since the simulation is about pressure ulcer, it's good to start with the definition of pressure ulcer. Now, I'm going to spend a little bit more time with the definition here, because it can help us in terms of not just accurately diagnosing an etiology of the wound, so we know how to manage it to prevent it, but also it can help us when it comes to our documentation. So what is a pressure ulcer? Now, a pressure ulcer, per definition, is a localized damage to the skin and or the underlying tissue. Now, per the definition itself, it's this localized damage. So the word localized, if we want to support our documentation, we need to elude that. So for example, linking it to documentation, category 2, pressure ulceration localized to the sacrum. A spread out damage to the skin is slightly different. So highly likely that could be an indicative of potentially a moisture associated skin damage. So again, going into the definition and how we document. So generally, pressure ulcers is localized, circular in appearance. Now, the injury is usually over a bony prominence, okay? So usually over prominence, or related to a medical or other devices if it is away from a bony prominence. So let's reflect documentation. So when you document a skin injury, if you think it's a pressure ulceration, then you think wound or pressure ulcer to patients healed over a bony prominence, X, Y, and Z. If it's away from a bony prominence, we then document what potential medical device or other device that is in close proximity or contributing to the development of that pressure ulceration. Okay, so per the definition itself, it's already leading us in terms of how we document accurately to support our assessment process. To continue with the definition, a pressure ulcer can also be a combination of the pressure with shear. So if we think shear is a contributing factor to the development of pressure ulcerations, then we need to stipulate that from our documentation. So following on today's session, you're thinking, Roma, I really don't know what understand shear is. It's something for you to perhaps explore after this webinar. And a pressure ulceration can present as an intact skin, or also a clear fluid-filled blister or an open wound. Generally can be painful, or it occurs, so this is important, as a result of intense and or prolonged pressure. In the absence, again, of intense and prolonged pressure, we could be looking at something else. Because if we're looking at contributory factors that are outside the definition of pressure ulcerations, highly likely we're dealing with a different type of wound. So let's focus in terms of our diagnosis within the remit of the definition. And that would help us in terms of accurately identifying a wound or a pressure ulcerations, then leading us into an accurate management strategy on how we manage this type of particular wound. And I hope that makes sense. Okay, if you have strong objection about it, type it in the chat and we can hopefully have a discussion after, or hopefully Kirstie or Charlie will be able to help in terms of answering some of your queries. So why are we focusing on pressure ulcerations? Now, despite the government's effort, the NHS efforts really to try and implement different strategies to reduce pressure ulcerations, and I'm also talking globally, you probably will hear about the Stop the Pressure campaign a couple of weeks ago that was done globally to raise awareness and the profile of pressure ulcers and how we prevent them. We're still seeing a significant amount of patients affected by pressure ulcerations. Now, it's about approximately 700,000 patients are affected with pressure ulcers per year. And to think about it, there's a significant amount of patients developing pressure ulcerations, okay? And in terms of managing these pressure ulcerations, it's costing the NHS about 4% of its total expenditure. In pounds and pence, that's about 2.6 billion. That's a significant amount of money in terms of managing pressure ulcerations. And part of the contributing factor to that is, how much a pressure relieving equipment costs nowadays. If you think about the electricity, if you've got a pressure relieving equipment that would be plugged in, for example, your time spent in managing these wounds and perhaps extra resource to implement the repositioning regime, particularly if these patients are out in the community setting. So it's a huge challenge from the NHS looking at budget-wise and managing this, and really equally for patients. And from a patient perspective, I'm going to go down into the bottom bit of the slide there. Pressure ulcers can be life-threatening and can increase in mortality, particularly if patients are admitted to hospital and develop pressure ulcerations. It increases their mortality of about 5% or above due to the complexity of pressure ulcerations and potential complications of pressure ulcers that can compromise the patient's health and ultimately, it become life-threatening. So I'm talking about potential osteomyelitis if the bone is exposed. I'm talking about category 4 pressure ulcerations, or particularly patients with diabetes, for example, and develop pressure ulcer on their heels. So healing is already compromised because they're diabetic, paired with a complex wound or a wound with potential risk of osteomyelitis, absolutely catastrophic. And the significant impact of pressure ulcerations on patients' quality of life. I remember, and I always share this story when I do pressure ulcer sessions. I was involved in an investigation of a patient following a liver surgery, liver transplantation. The whole transplant procedure, absolutely fine. She went to theatre, she had great recovery. But while she was in ITU, she said to the nurse, "My bottom is sore." And what the nurse did is she applied a cream over said sore. And that's about it. And consequently, we know we need more than that when we manage pressure ulcerations, really. Probably not a cream, really. It should be the first management strategy here, but that's what happened. And she consequently developed a category 4 pressure ulcerations across the sacrum and the buttock, bone exposed. She went to theatre and had a surgical debridement with plastics, and she ended up having negative pressure wound therapy to speed up the healing process. Discharge in the community with this diagnosis to manage. When asked about her experience of her liver transplantation, all she keeps on saying, surgery absolutely fine, but the most horrific or nightmare for her as a patient was her pressure ulcerations. The smell of the wound really bothered her. She thought that there was some dying tissue that she can't see, and she's very concerned of it. The position of the pressure ulceration, it's in an intimate area. So every time different healthcare professionals will come in, change the dressing, even in the community equally. So she felt that her dignity was absolutely breached, and she felt that she'd lost control. She cannot do what she was expecting to do after a liver transplantation because she was almost confined to bed to relieve that pressure with the limited ability to be able to go out and enjoy and hopefully a good quality of life following a liver transplantation. So it is a wound that absolutely can become very complex and will affect patients' quality of life, and thereby, from a clinician's perspective also, very, very challenging to manage, very, very challenging to manage purely from the location and how pressure ulcers develop. It's hard to relieve really pressure fully. So all what we can do is try and mitigate those risks in terms of reduction of pressure to their particular area. So that's the impact of pressure ulcers to patients, and probably more. Feel free to share it in the chat if you have experience or your patients have shared some experience with you in terms of their personal accounts when they experience or sustain pressure ulcerations. With this type of complexity, it's important to have that almost consistency or recommendations in terms of pathway and what we do. And the good thing is, more and more now, we are considering national recommendations or best practice guidance and have our individual policies and procedures and pathways to follow within our own clinical area. You can see on your screen now this presentation is based on the EPUAP, so that's the European Pressure Ulcer Advisory Panel as a reference. So you will see a category 1, 2, 3, and 4 in front of your screen, which the EPUAP will encourage you to categorize the pressure ulcerations. And we also have unstageable and deep tissue injury. Unstageable is when we can't ascertain the exact depth of the wound, or we can't see the base of the wound, thereby we're saying that it's unstageable. So for wounds covered with devitalized tissue, i.e. slough or a necrosis. We also have a deep tissue injury. So what that means is it almost like when a skin changes, appears purpley or maroon discoloration. More often than that, it's intact, and some may present with like superficial break, but it's the almost bruising appearance, and highly likely shear would be involved in the development of deep tissue injury. So those are some of the classifications to consider. So it's important to reflect on what type of categorization you are following, and be confident in terms of how we categorize pressure ulcerations, purely because if we don't get it right, then we can lead into a wrong management strategy if we talk about a clinical pathway. Now, the National Wound Care Strategy Program is another organization. Now, they have been disbanded, but their recommendations remain relevant, and a significant, I would say, significant number of organizations within the UK are still following the National Wound Care Strategy Program in terms of categorization of pressure ulceration. Now, the main or the key difference here is if you're following the National Wound Care Strategy Program recommendation is you've got a strict 1 to 4 categorization. So the unstageable will automatically be categorized as category 3, just sort of like a reminder on that. And once we prepare the wound, reveal the true nature of the wound, then we categorize it accordingly. So it's either remain as a category 3, or it will be elevated into a category 4. Deep tissue injury will still need to be recorded, and we still need to follow pressure ulcer prevention and treatment strategies really for this group of patients. But again, in bold capital letters there at the base, follow your local policy for pressure ulcer categorization. So it's just important to highlight that. Talking about policies and procedures, so this is an illustrative case study of a particular patient. An elderly gentleman suffers with frailty, and he fell at a care home. He was taken by an ambulance to A&E. The patient was triaged timely and was seen by a medical doctor timely in A&E, which is great, good news there, and decided by the medical doctor that this patient needs to be admitted for further observations prior to discharge. Brilliant job from an A&E perspective. They've done the Waterloo Risk Assessment Score. So Waterloo Risk Assessment Score is a risk calculator, very popular years ago, but now purposely is the most accepted tool for risk assessment. But if you're still using Waterloo, absolutely fine. So they've done the Waterloo score. They've identified the patients as having a higher risk of pressure ulcerations, and they nurse the patient on a biflex mattress on a trolley. There's no available bed in the hospital, so this particular patient waited in A&E for about 16 hours. Whilst in A&E, the patient developed multiple pressure ulcerations, 2 category 2 and 2 category 3 pressure ulcerations. During the investigation, in terms of claims and negligent, and it transpired that during his stay in A&E, that the A&E staff failed to follow the 2-hourly comfort round. If that is the policy and procedure within the A&E, 2-hourly comfort round, we must adhere to it, because that's the expectation of the public and the expectation of the patient. So there's poor documentation of that, and there's poor documentation in terms of nutritional provision. So there's big lapses in care, particularly in a repositioning perspective, which is important when we talk about pressure ulcer prevention. So this particular illustrative case study, they were awarded their claim purely because of that lack of care or lack of evidence that care has been delivered in terms of repositioning of a patient and provision of good nutrition once the patient is A&E. Now, this particular case highlights that we need to be aware of our local policies and procedures so we know the expectations of patients and the public. But equally, if you are listening to this webinar and you are a policymaker, it's about making those policies and procedures achievable to the members of staff so we don't set them to fail. So it's just food for thought. It's something to think about from that respect when we talk about recommendations and clinical pathways and how staff are following them, supported with good documentation. In the theme of hospital-acquired pressure ulcerations, I don't know about you, but not everybody is familiar about NHS resolution. Okay, I'm just going to pause there. NHS resolution. I think, what is that, Rommel? So NHS resolution is an extension arm of the Department of Health to try and safeguard or help control the budget of the NHS. What I mean by that is it's judging or awarding litigation claim from the public or patients against the NHS. So it's got a total budget of 199 billion pounds. So the NHS is setting aside a significant proportion of money to resolve some of these cases that are coming through, really, when it comes to negligent claims and malpractices, I suppose. So, and I think our duty within this is to help the NHS protect this budget. Okay, and for the purpose of this webinar, really, it's about good documentation, because our documentation can support a lot when it comes to what has been delivered in terms of care to patients, because I'm sure we are all in agreement that as healthcare professionals, we take our responsibility seriously and really deliver the best that we can for this group of patients that we are nursing, if we are nurses. And but sometimes, and I think this is the reality because of the pressures in terms of how much resource we have, and what will happen sometimes is what will suffer, I guess, is poor documentation. It almost becomes like a second thought for us, but hopefully after today's session, that will bring the importance of documentation to the forefront of our mind, that we need to do this again for our patients, for ourselves, to protect ourselves, and to protect the NHS, and to protect this NHS resolution, to keep that budget within the NHS, because we know the NHS is in a significant crisis when it comes to funding as of the moment. So it's important to contribute, and how we can do that is good documentation paired with good care, really, to patients. So if we're looking at statistics, so total payment 2021 up to 2022 were about 2.4 billion pounds was awarded to claims that was put forward to the NHS. That's a significant amount of money. Okay, so each claims represent a patient journey or experience where the NHS has failed to meet expectations or standards. That's when the NHS resolution will award. Now, when we look at that, it says where the NHS has failed to meet expectations or standards. More often than that, probably not. It appears that way because we can't prove it. We can't prove that we delivered the care because of that lack of documentation. And consequently, if patients experience harm or suffer, that's when litigation will come, and then that's when they will be awarded against that claim. But yeah, something to reflect on when it comes to helping our NHS, protecting our patients and protecting ourselves. If we encounter clinical incident within our own clinical practice, gone are the good old days of the root cause analysis, which felt very much pinpointing who's to blame, really, when we talk about root cause analysis. Please share in the chat if you've got experience or bad experience about root cause analysis. But what we have now in most NHS organizations, I'd like to think is the PSEP system of incident reporting. So it's not so much of investigational framework, but looking at system-wide learning with PSEP. So it's about declaration of the clinical incident, verification that indeed this is a clinical incident, and looking at this incident with compassion. We may involve the patients, we may involve their loved ones in terms of systematic learning or teasing out the learnings from this particular clinical incident. So as I mentioned, it's not about blaming certain individuals for said incident, but looking at trust-wide, for example, if you like, or localized learning or system learning on how we do a true PSEP when we do this, when we follow this type of framework. I think hence why the NHS is going with this type of strategy, really. So it's about the supportive oversight, focusing on strengthening response to system functions and improvement. And that is the main purpose of a PSEP. It's there to look at how we can better ourselves and how we can better deliver patient care. In an event when catastrophic failure, I'd like to say, happens, and we're facing a situation where we completely fail to deliver the care that a patient deserves, these are some of the possible consequences that could happen. We could face NMC fitness to practice. I hope not, that would be frightening. Or employment tribunal, for example. Civil claim or negligence. So we talk a little bit about that from a patient perspective. Now, we are living now in a very litigious sort of, I'd like to say, litigious community. Even if you search online around pressure ulcer claims or negligence, you can see it, no win, no fee, that kind of narrative online services that are being offered there. You can also see it's almost they're equating category 2 equals to this how much in pounds when it comes to civil claim and negligence in terms of compensation. I think one particular case I was involved with, this is just in brief, in the purpose of time, is one patient received £25,000 in compensation because of inaccurate risk assessment. They were doing Waterloo then. Now, considering this patient is non-concordant and got difficult, but the documentation was very poor. So we are unable to establish what's been discussed, what preventative measures have been put in place, apart from the inaccurate risk assessment for said patient. To the extreme, if a patient suffers sudden death, for example, an unexplained death, that's when a coroner will be involved to explore that, okay, which we'll be exploring even more as we go through this webinar. Hopefully, I think, with good documentation, really, I don't think we'll be facing these consequences here. But it's something to, to be aware of as a reality check, really, what could happen if we don't get it absolutely right for our patients. Accountability. I think as registered practitioners, we need to take this accountability really, really seriously. And it's about understanding what accountability is when it comes to our own clinical practice. We may, judgment or clinical decisions in every day on our clinical work, that what we do, we hope that it's evidence-based, it's following policies and protocol, because we feel that we're accountable for those decisions that we make. But equally, there's also that line between what is accountability and what is responsibility. Everybody is responsible in implementing a pathway, but perhaps a few people are accountable for what that pathway would look like. And again, if we talk about escalation, for example, is passive. Once we escalate that particular patient to somebody else because we don't know or we need help, and again, are we passing fully the accountability to said professional? So again, it's something to think about. It's something to think about. But I think from my perspective, when we are nursing a patient, for example, looking after patients with quite complicated needs and complex issues that beyond our skills and remit, it's making sure, and I think it's about the escalation and looking at our own accountability and limitation of our own practice, and making sure we reach out to those people that are able to help us, because there will always be somebody there to hopefully help. So yeah, it's good reflection in terms of accountability versus responsibility there, and escalation. Professional duty of conduct. When a clinical incident happens, it's about taking ownership. Now, this is about being open and honest to patients and their loved ones, really, as part of how we deal with clinical incident. It's about, I think, it's just saying sorry. That it's about saying to your patient to say, I'm sorry that this happened to you. It's acknowledging it. Because I think from a patient perspective, looking at some of the feedback for clinical incidences, the worst thing you can do is to hide facts from patients. But I think honesty goes a long way when it comes to acknowledging a clinical incident. Now, acknowledging a clinical incident and saying sorry doesn't mean that you've taken full accountability and you are taking the stance that you are at fault, or the NHS or the organization that you're working for is at fault. Because generally that is the connotation that some clinicians will think about duty of conduct. No, it's not all about that. It's acknowledging that the situation happened, that we are sorry of that situation, and we are making things better to hopefully prevent that from deteriorating or similar incidents to happen in the future. And that is part of our responsibility as clinicians to do that. I'd like to think that we're getting better at it, because I think I still remember when this first came in terms of duty of conduct, and they always said, Tissue Viability Nurses to do that. I remember I get a referral to say, I've got patients with category 2 pressure ulcer there. Can you break the news to the patient as part of duty of conduct? Right. When it first came out, I used to support them, say, yeah, all right, I'll go there and explain it. But no, it is all our responsibility. And I guess those type of referrals comes from, the lack of understanding on how to explain, on how to follow the process, so explain indeed potentially what a pressure ulcer is and how potentially pressure ulcer can happen. But it's about, being open and honest to your patients and, earning that trust. Because you really don't want to break that trust between patient and healthcare professionals, because that's when negligent claims, complaints will happen if we broke that trust. So we need to keep that trust for these vulnerable patients that we're looking after, and part of that is being open and honest. Okay. So, as mentioned earlier, if there is a natural death, sudden death, a coroner will be involved, and that is just by law, really, because the duty of the coroner will explore the easy questions of who the disease was, how the disease came to their death, when and where they came by their death. But generally, the how is the most challenging part from a coroner's perspective when we're looking at sudden death or suspected death. That could be violent or unnatural causes from that respect, but that's when the coroner will be involved. And later on, in the second part of this webinar, we would like you to take the role of the coroner. So when I say the role of the coroner is, we'd like you to really focus on the how. particularly with the case scenario, how the patient came to their death. And we would like you to deliver your own conclusion or verdict, if you like, at the end of the simulation. Okay, but that is the main remit of the coroner. The coroner can also conduct a pre-inquest hearing. That means if the inquest cannot be held within days of the patient's passing, so the coroner will conduct a pre-inquest hearing. The purpose of it is almost administrational, really, looking at the evidences, the process of how the inquest will go. Do we need a jury for this particular case? Quite rarely a jury will be required, but if it is to be required, then the pre-inquest hearing will determine that. But as I said, the coroner's inquest is a legal inquiry to the death of an individual. It's a natural, violent, or suspected, unsuspected cause. If you're lucky enough, and I'm saying that jokingly, to be invited to produce evidence, for example, or to be an expert witness to a coroner's inquest, your duty, I'll take this slowly, your duty is to the court and to the coroner. Yeah. So, and they will expect you to answer the questions as accurately as possible under oath. The main purpose of the inquest is not to apportion blame, although it may feel that way, pretty much similar to the previous root cause analysis. But really, the main purpose from a coroner's perspective is to really determine how the patient came by their death. And what is important is to get the accurate facts on what actually happened, and your documentation will support that. Okay? Your records are valuable to support the answer in the coroner's question. Again, your documentation will support that. It might be, if you have experience being invited to a coroner's court inquest, either as a witness or to create a report, feel free to put it in the chat. Yeah, put it in the chat now. I'll give you a chance to see. It'd be good to draw from your experience later if we have time. But tell us how that experience was. I attended a symposium a couple of weeks ago of a tissue viability nurse accounting his experience when he was asked to produce evidence for the coroner's court, and when he was asked to be an expert witness for the during the inquest, and he was absolutely terrified. He felt that he could lose his license. He felt that it would be the end of his nursing career. But it sent a shiver to some people. But I think after he shared that experience, but actually when he was actually in front of the coroner, that perception completely changed. So he fully understood that really the purpose of the procedure is about finding out how the particular individual came to their death. It's not about apportioning blame, because that is the sole purpose of a coroner's inquest. And he did relax a little bit. And I think he felt that sense of duty to share that experience, because he felt that if anybody would be invited to produce evidence or be an expert witness to a coroner's inquest, he doesn't want anybody to have that similar perception experience than when it happened to him. So that was a really good session. So, and hopefully after today, it will be in our psyche that actually this is not about apportioning blame to you personally, but this is just about fact finding. And yeah, let's reflect on our documentation, because my memory is absolutely shocking. So if I will be invited to to be an expert witness to some of the patients that I cared for, probably how many years ago, I would struggle to recall without looking at my documentation. And so I always tend to not necessarily War and Peace, but I make sure that, you know, documentation piece, I've documented everything. So the conclusion. So after a coroner will conduct an inquest, he will deliver his verdict, if you like, or facts or a conclusion. So there are potentially 6 conclusions after an inquest. What you can see on your screen, the top 3, pretty much straightforward, natural causes. That's quite straightforward to deliver. And I think a good medical report would suffice. The accidental death or misadventure. Overdose on drugs, for example, is one of a good example of that. By accidentally taking these weird and wonderful drugs, for example, if you're on holiday in Ibiza, I don't know where. Unlawful killing. That's, I think, I'd like to think that's straightforward. Murder or manslaughter. Suicide, yep, straightforward. But I think in terms of neglect and narrative verdict, that can be sometimes tricky to decipher, if I put it that way. So I'd like to take a little bit of time explaining what a neglect and a narrative verdict is. So if we look at neglect in terms of per definition for these presentations, neglect, you deliver a conclusion on neglect if there is a gross failure to provide the deceased with the basic needs. Okay? So think about it later when you deliver your verdict, that if you choose a neglect verdict, that there was a gross failure to provide the deceased with basic needs. What are our basic needs? Food, water, warmth, clothing. So those are the basic needs. So really, for us to deliver a neglect verdict, there has to be an absolutely catastrophic failure to deliver some form of care to said patient. We've failed to provide basic needs. We've failed to provide this patient with water and food and clothing. So it's actually really, really damaging to have a neglect verdict. It's just something to take in mind. Narrative verdict. The coroner will set out the circumstances of the death in a detailed way based on the evidence heard. Meaning to say, there's multiple factors causing the sudden death of said patient. Okay, so there could be lapses in care, gaps here or gaps there in terms of care delivery. But really, from a narrative verdict to stand, that they have to deliver, or there is enough evidence that said organization has provided basic need to the patients, but experience lapses in care. Hence, that led to the patient to their death. Is that clear? I hope that's clear. I'd like to think it's a clear definition there, but we're all passionate clinicians, and sometimes, yeah, that a bit muddled. But just focus on the basic needs, and narrative would be patients receive basic needs, but lapses in care. If the coroner will deliver a conclusion of a narrative verdict, he or she can also issue a Regulation 28. So what is a Regulation 28? So this happens when the coroner has heard evidence that further avoidable death could happen if preventative actions is not taking place. So during the inquest, if the coroner felt that that particular organization did nothing to prevent future death from happening, it is the interest of the public that the coroner will issue a Regulation 28. Because what the coroner is thinking is, I don't want future death to happen if more patients will come in to said organization. Okay, so during the inquest, it is the responsibility or the organization that potentially being accused of negligent of care. It is their duty to outline that they put some measures in place to avoid Regulation 28, because Regulation 28 can be damaging to the trust reputation. So any organization or NHS organization will try their best to outline that they've done what they could to prevent Regulation 28. So thereby your record keeping is absolutely important when it comes to defending care delivered. Okay. What applies to good record keeping? What you can see in front of your screen is what will be considered as admissible evidence when it comes to record keeping during a coroner's court inquest. I'll just focus on a couple of things for the purpose of time. Photographs, great. It actually outlines the appearance of the wound, particularly when you've got different wounds. sporadic ulcers in different locations. A picture can paint 1,000 words. So, yep, consider photography in that respect. I think telephone conversation. Do we record it all the time? Perhaps not. If those are really, important conversations that can lead into either omission or potentially altering a patient's care plan, absolutely record it, time, dated, who you had conversation with. Okay. Do you do that? If you do that, say yes to the chat. I'd like to think that you're still listening to me, because it's quite sometimes I'm just facing in front of my screen now, so I'm not sure what's going on. Oh, yep, thanks, Rebecca, you're still listening. Oh, thank you for that. Great. I'm not
There
sure
is
whether you
lots
raised
of
your hands.
yeses going in the chat, Rommel. The chat's
Fantastic.
actually quite active with some discussions going on in the background, so people are listening and you're provoking a lot of insight and a lot of thought.
Oh, thank you, because I suddenly felt lonely here. I was just thinking, yes, great, thanks, Kirstie. So yeah,
No, we're all
telephone
being
conversations.
keyboard warriors in the background, so don't worry.
Good stuff, good stuff. Let's move on. Right, I'm just gonna leave that there. Yep. If it is not recorded, it didn't happen. Yeah, I know what you're thinking. I know what you're thinking. If it is not recorded, it did not happen. I'm going to say it again. If it is not recorded, it did not happen. And it's so true. When it comes to, in the context of a coroner's court inquest, yeah, the coroner will go with evidence, reports. So if it is nothing documented there, it's hard to substantiate that care has been delivered. So we need to make sure that we document the care that we delivered. Common problems when it comes to documentation is the absence of clarity. We need to add a little bit more context when it comes to documentation. I think I started with that really when I defined pressure ulcerations. And I think the next thing to point out really is failure to record actions taken when problems identified. Yeah. That is one of the most futile thing you can do. You've identified a problem and you just documented it without documenting the measures that you put in place. I'm going to go with a pedantic example here. Skin is dry or skin very dry, and you just leave it at that. Well, what did you do? Yep. Good skincare routine, moisturizing. Yeah. Ask somebody to perhaps prescribe it, or you prescribed it, that kind of stuff. So put the actions. If you identify the problem, put the actions on what you've done. If you don't know what to do, as I said earlier, always escalate. There's always somebody that knows how to do it. Some don'ts when it comes to documentations are in front of your skin. Leaking plus. Hopefully not. Gone are the days that we used to do that. I still remember it actually when I was doing it. How many moons ago? I'm showing my age now. Reposition where? Reposition to right, left, skin intact where? Yeah, to the bottom, sacrum, heels, that kind of stuff. Mattress ordered when and who? Yeah. Okay. So skin check. What did you find? Blanching, non-blanching erythema. Yep, example to your left there. Sacrum red. Is it blanching or non-blanching? Add a little bit more context.
Rommel, we've got a couple of people with hands up.
Yeah.
Do you want to take some questions, or do you want them to put it in the chat?
Go on. Yep, let's take the question.
Okay. Rebecca, I'll just allow your mic. So if you just want to ask your question.
Yes, Rebecca. Okay. Was it just a?
Might have been an error, one of them.
An error.
Yeah.
Okay.
And then we've got Monica's got her hand up. I've allowed her mic. So Monica, you have a question if you would like to ask it now.
Oh, don't be shy, Monica. Okay.
No, again, must have just been
okay. In the interest of time, I will continue. Let's put it on the chat, hopefully. But don't be shy. If you got any questions, yeah, feel free to speak. So yeah, it's about adding the extra layer of information to provide that clarity when we talk about a documentation. Wound deteriorating. I just think, well, that's just a red alert from my perspective. So what did you do? Yeah. Did you take a wound swab because of wound infection? Did you refer it to somebody else? Did you ask your link nurses to help you in terms of management of this wound? Did you consider more debridement? You know, those management strategies, for example. Okay, so add a little bit of layer. So that's just documentation, or the importance of documentation. I'm going to touch on now on the 3-step approach by Coloplast, because when we talk about documentation, we can be successful with accurate documentation if we are following a simplified approach when it comes to management of, for example, hard to heal wounds or any wounds. And here in Coloplast, we're all about simplifying care. So simplified care can lead into hopefully support your process of documentation much easier, because certainly I do this in my own clinical practice. So from a Coloplast perspective, we talk about the assess, prepare, treat pathway, which is a quite good pathway to follow. So it's about assessment of the patient to start with and assessment of the wound. So you can reverse it whichever order, but from an assessment perspective, we need to consider patient's perspective. Are they engaged? We need to get the agreement in terms of treatment management and what this potentially wound is and what we expect them to do. And from a wound perspective, we need to look at the wound bed, the peri-wound skin, and the surrounding skin. Okay, so again, power of 3 there. So thorough wound assessment and thorough patient assessment. And once we've assessed that wound thoroughly, and most likely we probably will see devitalized tissue, we need to prepare those wounds to healing. And part of that is mechanical debridement. And I guess most of the audience here are generalists in terms of what we do. Following wound preparation is implementing a simplified dressing regime. What I mean by simplified dressing regime is dressings without layers of layering and layering of different all sorts. So go for dressings that can maximize or can manage most of the symptoms that a wound will present in front of you. And it's important to acknowledge that the gap in the wound bed when we're talking about treating a wound. Now, about 80% of the wounds that you potentially will be managing will up to 2 centimeters in depth. That's the majority of your caseload, really. So think about a management strategy that can manage that gap. Because if we fail to manage that gap, what will happen is bacteria pooling. Once bacteria pool, risk of infection, complications of proliferation of the bacteria, and potentially, if we talk about the peri-wound skin, that can progress into maceration and wound expansion. So think about that. And when we look at the wound bed, so not just the gap itself, look at what we can actually see. So not just the actual depth of the wound, and acknowledge the presence of devitalized tissue. A significant proportion of clinicians when survey felt that, and actually it's about 60%, I think it's probably higher. I would probably say more than 60% of the wounds out there are not being prepared thoroughly. I think gone are the days that we tend to anoint wounds, just pour a little bit of saline, dab, dab, dab. Let's not disturb this wound because we want it to heal and we don't want to disrupt anything that's going on at the wound bed. Gone are those days. We need to change practice. We know from evidence 80% of wounds that we're dealing with are infected with potentially a biofilm-related wound infection. And outside of that, the significant, or there's devitalized tissue present at the wound bed, we need to get rid of them. Okay, we can see devitalized tissue, we can't see biofilm. So we need to be thorough when it comes to wound preparation. And here at Coloplast, we have a solution for that. We have all prep pad, because from a mechanical debridement, it needs to be easy to use from your perspective and from a patient perspective. I use it in my own clinical practice when I was running a clinic probably about 2 months ago. And it's easy to use. It supplements my skills in sharp debridement, but equally patients find it easy to use. This is important and vital when we're managing not just pressure ulcers, so difficult to heal pressure ulcerations as part of a wound care plan that we need to consider wound preparation. And that can be done with an all prep pad. If you want to know more about all prep pad, just put your contact details in the chat, and hopefully Ben will pick it up and we can pass your information to somebody. But again, the emphasis here is about good wound preparation to reduce the bacterial bioburden, and get that wound into a good healing momentum. We need to heal the wound rapidly, so we need to employ new strategies. The quicker we can heal those wounds, few complications in terms of wound infections, etc., etc. Okay. Once you prepare that wound, treat that gap. Okay. And a simplified approach, in this particular case, what you can see is a biotin silicate. Our biotin silicone will do the 3D fit technology. What that means is it conforms into the gap without the need of a filler. So it's simplified the dressing regime for your patients. So even if you got, I call it cavity or a gap in that wound bed, so up to 2 centimeters with the absence of tunneling and undermining, you can just put a biotin silicone as a simplified dressing regime, more cost effective, and more patients will be able to follow this type of dressing regime when it comes to potentially asking them to participate in their wound care. So I'm talking about supported self-management. At the end of the day, it's their wound, and we are there to help them. And a simplified approach in cleaning their wound, managing their wound, would give them the confidence to participate in their care. This is important to consider that. And of course, we document it after. Okay, so make sure we remember that good documentation, simplified thought process when it comes to clinical pathway, and simplified wound management. So what you can see in front of you is a case study of Jamie, who is a 39-year-old male. He suffers with ischial pressure ulceration to his ischial area for about 15 years. He's a young guy and still very much active, and he still works, and his work involved a lot of sitting. So thereby he developed these pressure ulcerations. And what you can see in front of you there is a wound bed covered with devitalized tissue, a little bit of slough there, and mostly macerated tissue, really. And if we don't remove it, it will become slough, X, Y, and Z. But yeah, not a healthy tissue there. We need to prepare it. So they tried all prep pads to remove those macerated tissue and devitalized tissue, and thereby reducing the bacterial bioburden. Once we reduce bacterial bioburden or devitalized tissue, we can expect wound exudate to go down. Because of tunneling and undermining, they treat this wound with biotin alginate AG, with some silver, because they felt that there's some bacterial load. It's quite elevated at the wound bed, purely because of the location of the wound, and they use biotin silicone to manage. And gradually this wound improved, this patient back to work and become a positive member of the society again, and more or less he gained his quality of life back. But you can see the difference there between day 1 up to day 16 in terms of how clean the wound bed is. And again, the importance of wound preparation and following that simplified dressing regime. I am now at the end of my session. This is just an example of pressure ulcer pathway. So if you haven't got a current pathway that you're following in your clinical practice, at the end of this webinar, along with your certificate and with the recording, we can also send you a copy of the pressure ulcer pathway from Coloplast for you to follow as a reference. It's very generic. It's highlighting what are the key importance, again, following the assess, prepare, treat clinical algorithm. And also a good product guide from Coloplast here when it comes to simplification of products choices. We have to simplify choices, otherwise everybody will be confused in terms of what they're doing. But always think of a product that can manage most of the symptoms of that wound bed. And with biotin silicone, apart from that 3D technology that you will get that conforms up to 2 centimeters in depth, it absorbs that wound exudate vertically and keeps that exudate that way. It doesn't allow it to laterally spread, particularly if we're talking about pressure ulcerations, because it will hold that wound exudate within the remit right up to that wound edge. So you don't have the problem of wound maceration, potentially leakage. Okay, so just some good examples there in terms of how to follow a simplified approach in clinical pathway, a simplified product choice. Again, once we've done that, we document. Okay, right. That's the end of my presentation. I'll need a drink. And I believe you've been very active, guys. So thank you for your participation in the chat. Any questions, actually? I've got about 2 or 3 minutes to answer any. Oh, thank you, Lauren.
There's no direct questions in the chat. Lots of discussion has been going on in the background. Especially with like duty of candor, things like that. Couple people are wanting some obviously information on all prep pad and products. Yeah, people have had some confusion over how long pressure ulcers can take to develop, but yeah, all answered
Okay.
and all sorted, but they've all been quite vocal.
Now,
We do have a hand up,
go on.
Carolyn. I'll allow my mouse will let me allow the mic. So if she wants to come on.
Caroline Blair.
Again, might have been a...
Yeah, hello.
Oh, there we go.
Hi.
Oh,
Yes,
hi.
Sorry, I didn't
That's
realise
all
I had to undo my mic. So, yeah, you mentioned prior that with uncompliant patients and documentation, how would we document patient being, is it incompliant, uncompliant? I can't remember the word.
Non-concordance.
Yeah, you know, we get a lot. I work in a rehab hospital, so we do tend to get a lot of the elderly patients. They just don't want to do anything, so it's quite difficult in documenting to try and word it correctly.
Yeah,
if that makes sense.
Yes. Yeah. I think from my perspective, number one is to establish the patient's capacity to start with, whether this patient has got capacity to actually participate in their care, to say no, to say yes to certain aspect of care plan. So we need to establish that, and that follows our documentation. In the absence of that, and you think, right, this patient is fully able to engage with the care and understands the information. From a documentation perspective, it's about outlining what you have discussed to the patient. So, for example, we've discussed pressure ulcer prevention and potentially the risk of what can happen if we don't comply with pressure ulcer preventative strategies. Despite that, patient chose to X, Y, and Z. So, my perspective is about documenting that they've understood what we're trying to present and the potential consequence of their action, and then document that. Failing that from a documentation perspective is also escalating it. Again, it's about escalation. If you have somebody to escalate, so get another member of staff potentially to discuss it with the patient or speak to their next of kin if that could be an option.
Okay.
The other thing I would mention is obviously if they continue to be non-concordant, go down like a safeguarding route as well, because there might be other teams out there that might be able to support and help you as well, and if it gets flagged to them, they might be able to support. And just because somebody's been deemed to have capacity on one assessment doesn't mean that if they're reassessed, capacity can fluctuate, it can change all the time. And like I said, if you're a rehab facility, then there could be an element of a delirium if they've been in care for a long period of time, all this other stuff. So yeah, kind of look along them lines as well.
Yeah. Okay. Wonderful. Thank you very much.
But great question, Caroline, really to reflect, because it is tricky when you're dealing with patients who are non-concordant in care. And again, you don't want war and peace, but really just cover some of those elements that we discussed and what Kirstie has potentially shared with you in terms of explorations of other means and solutions.
Yeah, there's a couple of people in the chat as well that have put that they have risk assessments in for things like that. So it might be worth seeing if your colleagues in the chat are willing to share what they look like. That might help you. It might be something that you may be able to develop yourself, that you could develop a pathway that might support you in your decision making and what avenues you can go down when people are non-concordant.
Yeah, that would be really, really interesting if anyone could. Sorry, I don't know whether you heard, I'm having a kitchen fitted, so it's just difficult, isn't it? So I quickly turned my mic off, so I do apologise. But yeah, I don't know whether we actually have that in place, but we do have a lady that comes in quite often. She's very non-concordant, and to the point where the DNs are refusing to go to her now. So she is in a cycle of bilateral leg ulcers, refusing to have them dressed, then get infected in the hospital. We sort it, she goes back out, refusing to have it dressed, and this is the cycle that we're having with her. So it is really frustrating, and the cost to the NHS is actually, obviously, it's just immense.
I think
You go, Rommel.
I think, you know, from a leg ulcer perspective, they are one of the most challenging patients to have when it comes to concordance, really, with treatment pathway. Now, without knowing what has been explored in the past, perhaps it's worth exploring what else, you know, really understanding in terms of why she's refusing certain parts of the treatment that you wanted to implement. You know, highly likely, possibly, I'm not sure whether public compression or the type of hosiery that she's wearing. So try and explore other alternatives. But if you've exhausted every means, then yeah, there's very little you can do apart from, yeah, just keep documenting. Kirstie?
I was just going to say the same thing, and like I say, quite a few people are interested in these pathways and forms and assessments that other people have. So yeah, sharing is caring.
Thank you very much for that. Anyway, I'll let somebody else. Thanks.
One person has put in the chat, legally, what is the difference between refused and declined? That's Fiona Cunningham. Fiona, there's not a legal difference. It's just more the connotation that's behind the word. So refused you would assume that it's a bit more polite, a little bit more pleasant, whereas declined, no, sorry, the other way around, declined would be no thank you, a bit more polite. Refused would be a bit more aggressive, and I think it just depends on how you interchangeably use the words. It's not a legal thing. We just have to say, like Rommel said in the conversation we've just had, it's more non-concordant than refused or declined.
Right, in the interest of time, let's give you 10-minute sort of break. So we should be back 2:15. Is that correct, Kirstie? Yeah.
Yeah, come back at 2:15. Give everyone's pressure areas a bit of a break.
Yep. Okay, see you guys in a bit.
See you in a bit. Hello.
Hello. I think, yep, we're still holding the numbers, so I think everybody's still in. So over to you, Kirsty.
That's fine. So, in the interest of time, because we've got about 45 minutes, we'll get started with the coroner simulation. So I'm just going to share my screen. Oh,
Audio.
we need to make sure we've got audio.
Yeah.
So what's going to happen now is you as the audience are now going to play the role as the expert witness and deliver your findings at the end. So the simulation will be split into 5 videos, and there'll be a poll and a brief discussion after each one, and then we'll come up with our verdict at the end. So we'll get straight into it with part 1, and you get to meet your coroner. So Rommel, can you just confirm if you can hear that?
I can't see anything, Kirsty.
You can't see anything?
No, I can't see your screen being shared. I can't hear anything either.
Let's try it now. Can you see it now?
Yeah. It's doing something. Hang on. That's it. I can see it now.
Go. Okay.
Yep.
I am
Can we hear?
resuming the inquest
Yeah.
into the death
Okay, right, let's get started.
of Elizabeth Black that was initially opened on the 3rd of April 2022. It is my duty today to listen to the evidence requested in order to assist me in answering 4 questions. Who the deceased is, when, where and how they came by their death. Who, when and where forward. It is how they came by their death I need help with. I can confirm that the deceased's full name is Elizabeth Mary Black, but her family have expressed a wish for her to be referred to as Betty throughout this inquest. She was born on the 1st of January 1934 and died on the 31st of March 2022 whilst a resident in Boot Hill Residential Home. In order for me to be able to issue a death certificate, I need to establish the circumstances surrounding the death of Betty. I will gather the evidence, and based upon that, I will issue a death certificate. Under Rule 42, no verdict shall be framed in such a way as to appear to determine any question of criminal liability or civil liability. Based on the witness statements I have to date, I have taken the decision not to call a jury in this case. I may have to reverse that decision should evidence come to light which would suggest a jury is required. In order to help me today, I have called several witnesses to court and have legal representation for the hospital, for the residential home, and a brief statement from the family. It may be that I cannot actually conclude death due to natural causes, depending on contributing factors and the evidence heard during this inquest, in which case I will form a narrative version. We have heard from the pathologist, who has identified the cause of death as 1A, sepsis, secondary to 1B, infected sacral pressure ulcer with signs of osteomyelitis in the coccyx, to a heart failure. Following a fall, Betty was taken to the hospital and was assessed in the accident and emergency department, where she was found to have sustained a fractured femur. Could Miss Brown come to stand? Please, can you confirm your name and your current employment?
My name is Miss Brown, and I am the Deputy Director of Nursing, representing the A&E and Orthopaedic wards.
When was Betty admitted, and what was she like?
Betty was first seen at the A&E department at 7:30 a.m. following a fall at her residential home during the night.
Was Betty triaged?
No, she had been brought in by ambulance.
Someone must have triaged or received a handover of Betty. How did the ambulance team hand over?
She was handed over to one of the night staff who triaged her. She was then put in reception on a trolley and was assessed by an A&E nurse at 9 a.m.
Why did she wait so long to see a doctor?
The department was very busy. The A&E nurses had numerous ward transfers. analgesia to administer, and overdue observations on 4 patients.
And what happened then?
She was heard to ask for help and was seen by a doctor who sent her for an X-ray, which showed she had a fractured hip.
And how long was she in X-ray?
Approximately 50 minutes, ma'am.
And how long was it in total before she went to the ward?
She waited 8 hours to be admitted to the orthopedic ward.
Why did it take so long to admit Betty?
There had been an outbreak of norovirus, so some of the wards were closed and the remaining wards were full.
So Betty spent 8 hours in A&E. What was Betty laying on during that time?
An A&E trolley.
Was Betty given any pressure ulcer prevention during that time?
I'm not sure.
Why are you not sure?
I cannot find any records to confirm. I'm sure we tried to turn her, but she was in pain.
Was Betty offered any pain relief?
I will need to consult the notes. Nothing is documented here to say that she had any pain relief.
Can I confirm what you said? Betty was on a trolley without any pain relief for 8 hours.
According to the notes, yes.
Did anyone ring the family?
No. It was assumed that the residential home would have contacted them.
Do you not think it was important to ring the family?
Yes, but I can understand why, as the department was very busy that morning.
Please can I ask whether Mr. Park, the solicitor representing the hospital, would like to ask any questions?
Yes, thank you. Ms. Brown, is it correct that you were particularly busy that morning as you'd had 2 major road traffic accidents in the night before?
Yes, that's correct. Apart from the normal high volume of patients arriving at A&E, the department was still very busy due to the RTAs, which resulted in serious injuries and one death.
Okay, and since this has occurred, you've put extra procedures in place to help prevent this situation from happening again?
Yes, we now have charts on the wall for each patient detailing their specific needs, especially for pressure ulcer prevention. Also, the trolleys and mattresses have been changed to assist with pressure relief, and we now routinely turn all patients.
No more questions.
Thank you. Can I ask if Mr. Smith, representing the residential home, would like to address the witness?
Miss Brown, were you aware that the residential home rang the family?
No, I wasn't aware. I just assumed they would, as it was one of their residents.
Were you aware the residential home sent a letter about Betty's medication?
Yes, it was in the notes.
Did you send a discharge letter back with her to the home?
Yes, as I said, all patients are sent home with discharge letters and copies posted to their GP.
Were you aware that when Betty came out, there was no discharge letter?
I wasn't aware.
This is not relevant at this time.
I agree.
So what, if you put your thoughts in the chat, everybody. Rommel, you're going to have to act as my eyes because I can't see.
Yes, I think, sorry, Caroline has said that she's hearing from the lady who is Mrs. Brown, the deputy representing the hospital, that she's stating things as a matter of fact, as if the coroner would know. So I think that's Caroline's comment. And I think I'd like to think that hopefully the pre-inquest hearing was already been done, so they've already looked at the evidences, and the presence of the Miss Brown is just to reaffirm things. But
yeah,
I think Nicholas,
the coroner would have received a report probably from the hospital as well. So there might have been information already in there that they assume that the coroner knows because of that report.
So there's a lot of comments about poor documentation in between teams. So that's residential home and to the A&E department. Very poor documentation. Again, it's coming through. A lot of assumption. What do you think of that, Kirstie?
Yeah, that tends to happen. What's the assumptions being made so far? Just about.
And I guess that they're probably
referring.
They haven't specified. So it's probably about who's making the phone call, I guess, to the family's relative. Poor documentation, while the elderly care, doing that pass onto the hospital passport, documenting everything about the individual. Definitely no oversight on the hospital side of things, no documentation. Again, it's coming through. So I think it's very clear there from Miss Brown that there's poor and lack of documentation.
Yeah. What's everyone's thoughts on how much time she spent on an A&E trolley?
Nothing is mentioned along those lines, but they felt that there's a long delay. So they have identified that this a long delay transfer to the ward. And again,
Yeah.
that lack of documentation, again, no pain relief.
No documented pain relief. She might have actually had some, but it just wasn't documented.
This is it. And I think, or it's finding the right documentation, isn't it? So
Yeah.
there's a lot coming through around, yeah, absolutely spot on about poor documentation, passing on assumptions on who's doing what and who's doing who.
So did anyone notice as well what the hospital solicitor was doing when he was asked to speak? What do you think? No?
Nobody has picked up on that one in terms of Mr. Park. And what's your thoughts on that?
So obviously he went on to say obviously that they had obviously put the more context around the situation. They'd had a road traffic accidents. There was an increased volume of patients coming through, but he'd stipulated hadn't he what changes had been in place, and it was backed up by that deputy director of nursing about, you know, there's now charts on the wall for pressure ulcer prevention. Trolleys have been replaced with mattresses to help provide that, and there's now regular turns in place. So yeah, that's one thing. And then obviously the residential homes did come back with about the discharge letter, so keep that in mind. But we need to remember when we're watching this not to look for the bad, we need to look for the good as well. So it's easy in the situation that we're in, and why we're hitting what we're kind of learning in the webinar is to automatically look for the bad, but we need to look for the good as well. And that's something that we can pick up on here, is that, you know, the hospital have put measures in place from the lessons they have learned, and that can be seen as one good thing that's come out of not the situation, but they've obviously learned lessons and put things in place to have just left things where that they are. What do you think, Rommel?
Yes, good point. And I think they're probably trying to, I think, avoid Regulation 28. I think that's what Mr. Park is doing. But absolutely right, for the benefit of the patients, measures are already in place. So they immediately learn from the mistakes and they put some measures in place. So that's a good positive thing. So, right, and I think in the chat, yep, there's a lot of comment, leading questions, no pain relief, no hydration. Okay, right, shall we conduct a poll, please? I think we're ready for the poll, please, Ben.
Just loading it now.
There we go. You can see the poll in front of you. Whose responsibility is it to contact the family? And we'd like you to answer the question, please. Whose responsibility is it to contact the family? Right, let's see how. So there's about 268 of you guys. So hopefully we can reach about over 100 or half of it in terms of responses. Let's go. It's about 90. Maybe we'll reach higher, 150. Let's go. In the interest of time. Okay, we're over 100. So Kirstie, what I can see here. Can you see the result? Or
I can't see anything.
Right. So the results are 71% of 121 responses. 71% felt that any of the healthcare providers and departments, so anybody's responsibility really, to contact the family. The nursing home responsibility 21%. A&E's responsibility is 5%.
It should be anybody really. If you're not sure it's been done, do it. The A&E department could have rang the care home. They could have rang and said, has anyone been contacted? The other thing that A&E could have done as well is ask Betty if she wanted her family to be called. You've got to think of the time in which all this happened. The care home might not have contacted her due to the early hours. You don't know what agreement and communications they have with the family. If they've said don't ring us before 7, don't ring us before 8. So it's opening that dialogue between Betty, the care home, and A&E and also it's also better to, you know, as a if I knew that my mum had had a fall and was in hospital, I'd rather have 3 phone calls than 1 or none. So yeah, so it's thinking about it that way as well.
Yep, well done, everybody. I think majority is in agreement, Kirstie.
Yeah. So what we'll do is we'll go on to part 2 now and see how the story develops.
Brilliant.
I'd now like to look at what happened when Betty was transferred to the orthopaedic ward. When was Betty admitted?
3:30 p.m.
And when did she go to theatre?
5 p.m.
What did they do at theatre?
They repaired her fractured hip.
And were there any complications?
No, she came back to the ward and was quite well in herself.
Clearly there are no complaints about theatre. She had uncomplicated surgery and came back to the ward.
That's correct.
Any pressure ulcers when she came back to the ward? When did you start mobilising her?
Betty suffered with slight dementia, so the bed rails were up.
That's not the question I asked you. I asked, when did you start mobilising?
She was not mobilised until 4 days post-op.
Why not?
A physio assessment was required before she could be mobilised safely. However, the on-call physio team was running on skeleton staff and had several chest physio patients to deal with.
Did you get her out of bed at all?
No.
Did you do any pressure ulcer risk assessment before she went to theatre?
No.
Why not?
It wasn't time. By the time she arrived on the ward, she was prepped straight away for theatre.
Was there any assessment after surgery?
I will need to check the notes. No, it would appear not.
Why not?
I'm not sure. We must have got her.
Did you put her on any special mattress that might have helped prevent pressure ulcers from developing?
No.
Did you turn her?
Yes. When we washed Betty in the morning and changed her sheets, but not regularly until the Sunday, when we realised she wouldn't have a physio assessment until Tuesday.
Why not?
Each shift, we were expecting her to be assessed, to be mobilised. So we didn't implement a turning regime.
Did you or your team undertake a risk assessment on Betty at any time?
No, not until the pressure ulcer developed on day 4.
When was the pressure ulcer first noted?
We noticed that her bottom became red on the 4th day.
How did you treat the patient?
We applied a dressing to it as it was weeping onto her nightie and bedclothes.
Was it working?
Yes, the dressing appears to have managed the exudate and was changed every 2 days.
Did it deteriorate?
Yes, it did.
Did you reassess Betty?
She would have been reassessed at each dressing change.
When was she sent back to the care home?
She was sent back to the home on the 12th of March.
I have no further questions at this time. Mr. Park, do you wish to ask any further questions?
Yes, thank you. Let me summarize. Your department were extremely busy and short-staffed because of the norovirus. Betty went to theatre and experienced no complications. She didn't fall out of bed because the bed rails were up. And the family seemed very satisfied by their mother's care.
Yes. At no point was any complaint made regarding her care whilst on the ward.
No more questions at this time.
Thank you. Mr. Smith, do you have any further questions?
I have no particular questions about her treatment, but was a discharge letter sent back with her to the home?
Yes, as I said, all patients are sent home with a discharge letter and copies posted to their GP.
So the care home did receive a discharge letter?
I would need to check the notes. It would appear that the letter was left behind and not given to Betty to take home. It is documented the discharge letter would be given to the ward clerk to put in the post.
Point out the discharge letter didn't arrive until 3 weeks later.
I don't know what happened with that.
Whilst I appreciate you were short of staff, the care home were also short of staff. Let me point out how residents don't get pressure ulcers.
This is not relevant at this time.
I agree.
It is quite clear she had a Category 4 pressure ulcer when she left the hospital and returned to the care home, where there was no discharge letter to advise the home of her current condition. Did you ask the district nurses to call?
An answer phone message was left for the district nurses to call at the residential home the next day,
What time was this done?
approximately 4 p.m. on the day of discharge.
Did you send a letter to the district nurses telling them of her condition?
No, usually the discharge letter would be passed on to them.
Did you ask the community tissue viability nurse to call?
No, I thought the district nurses would refer to tissue viability once they had assessed her.
No more questions at this time.
We now have a discharge process for all to follow.
Thank you, Mr. Park. Please don't interrupt. You'll have time to offer information prior to summing up on the case.
Right, Kirstie, there's
Yeah.
comments in the chat. So there's
Okay.
no excuse for not undertaking a risk assessment or pressure
Great.
ulcer, particularly around repositioning. Yep.
The only excuse that you would have is obviously in an emergency situation when it's obviously life limb, then that'd probably be your only excuse when
Yeah.
pressure area care is the least of your concerns. But yeah, I agree.
Yeah, risk assessment should have been done at each point. Stay in A&E, right into theatre and to the ward. Poor care delivery. It's worth sort of noting here. I think somebody is already using the word neglect, so I think it's quite a strong word to use at this stage. But
Yeah,
no
it's a quite
repositioning schedule.
yeah. So there is what you can define as lapses in care, but can we go down as the route of neglect? We'll see about that one. So it was said in the video, obviously the fourth day they noticed that the pressure areas were red and they were weeping, so they put on a dressing, but they don't actually state what category they're graded and categorized there the pressure ulcer at. The other thing that they said is actually that the family were satisfied with the care as well.
It's interesting, Kirstie, because I did ask the group to say whether there's any positives that worth mentioning following on to that. I'm still trying to find a positive comment, but all I'm getting is
one positive is there
lapses
was
in care.
no theatre complications. She got
Okay.
admitted at 3:30 and was in theatre by 5. So even though she had a long wait in A&E and was in there for a long period of time, she was still in theatre with it that day and was in very, very quickly. So there was no theatre complication, went straight there, no issues with obviously the surgery site. So there is a positive.
But thank you for pointing that out. But I think tough crowd here, yes. And, nothing has mentioned
They're
anything.
not seeing any
Yeah.
positives in this, are they?
No, I think they're well. I don't know whether it's right to assume that they're quite frustrated. I think I will use the words in terms of what they've seen so far, in terms of failure in delivering proper care, opportunity for improvements at almost every point. They've already seen that. Risk assessment has
Well,
not been completed.
Mr. Park did say that there've been improvements again made to their discharge process that everyone needs to follow. Again, trying to avoid that Regulation 28.
Well, yeah, there's another response to that. They appreciate the incredible work. Thank you. But there's still significant gaps in care cases. The staff may have tried to make relevant, staff should have made relevant referrals.
Oh, they're a tough bunch, this lot.
They are. Should the home have not accepted her back? That's a good question.
Well, to be continued.
To be continued. Yep, let's go. Thank you, guys.
Right, should we do the second poll and move on to video 3?
Yes, second poll, please, ma'am. Right, the second poll. Should we automatically put bed rails up for patients who have dementia? Okay, right, let's go. Yes or no? Should we automatically put bed rails up for patients who have dementia? We'd like your vote, please. Right, so far, Kirstie, 119 has voted. Yep, 99% said no. I'd like to think the one must be a mistake, but yep, 99%, 129 responses now, 134. 99% said no, it shouldn't be done automatically.
No, it shouldn't be done automatically. An assessment needs to be made on each individual, and you've also got to understand the situation that Betty's in as well. She may have dementia, but she's had an anaesthetic. She's going to have had morphine, loads of other concoctions of drugs for her surgery. She's probably got antibiotics as well, potentially. You don't know what, we don't know the reasons of why she had the fall in the first place. So, all that to consider, so that could make her even more confused. So if the automatic bed rails up, it could cause a further complication. She might have a fall trying to get out of bed. So all that needs to be considered.
I think, yep, brilliant. Thanks, Kirstie. Yep, we're ready for part 3, please.
All right, let's continue on this episode of EastEnders.
Tough crowd. Look for positive guys if you can.
Can Mr. White come to the stand? Can you confirm your name and your current employment?
I'm Mr. White, and I'm the manager of the residential home.
You are one of the senior nurses?
No, I'm the manager, but not a registered nurse.
How long have you worked there?
For approximately 10 years.
You know your residents well?
Oh, yes. I work predominantly days, so I get to spend a great deal of time with all my residents.
Now, can I first of all ask you to run through Betty's situation?
Yes, Betty was found on the floor during the night between the commode and the bed.
Did Betty have bed rails up?
No, Betty was quite independent with her frame and could get out of bed herself. She had been doing this for the past 5 years. Her family knew that she could quite safely potter around the home and would have her buzzer if she wanted us.
And is it correct that she was found at 6:15 a.m. in the morning?
Yes. One of the carers found her whilst doing his hourly rounds.
When was she last seen?
According to the carer, he went round at 4 a.m. and looked in on Betty, who was fast asleep in bed.
Did Betty normally go to the toilet during the night?
Yes. She had her buzzer, but would normally use her commode herself and would only ring the buzzer if she wanted a cup of tea.
Had she rung the buzzer that particular evening?
No, on this particular evening she had slept very well.
And did you hear any noise at all?
No, nothing. The carer just popped his head in that morning to check on her, as he would normally do.
And what did he find?
He found Betty on the floor between the commode and the bed. She didn't have a Zimmer frame with her this time.
Was Betty able to tell you what had happened?
Not really. She was, well, how shall I say? She was a happy but confused lady. She said she'd fallen, but the carer said she'd wet herself, so we assumed that she'd fallen trying to get to her commode.
And what did the carer do?
He pressed the emergency buzzer and called the senior carer on duty, who decided to call an ambulance as Betty's leg appeared to be shortened. She also appeared to be in a lot of pain, so the carers didn't want to move her.
And Betty was taken to hospital?
Yes, the paramedics arrived, gave her some pain relief, and took her to hospital.
And how long did it take?
They came within 20 minutes. Paramedic arrived initially, followed by a 2-man ambulance crew. They made her as comfortable as possible and then took Betty to hospital.
Right. There's quite a few comments in the comments. Kirstie, I think they identified the timeline about 4 a.m. and Betty was found, they said around 6-ish on the floor, so they've identified a gap there. Not hourly as the residential home policy stated. Unwitnessed fall. There's some comments around that.
So that goes back, I always like to say that goes back to the first video when they said in A&E they were doing fall checks and obs for the falls. She was on witness fall, so was that being done on Betty as well? Has that been taken into consideration? Yeah, so again, she had no bed rail. She was independent with a frame for 5 years. She was happily but confused.
Carolyn said, where's the Zimmer frame?
Yeah, where is the Zimmer frame? That's not
exactly
mentioned, is it?
Nowhere can be found.
Yeah, nowhere. So is that she had a fall because it wasn't within reach? You have already pointed out, you were hot on that one about the, it's not hourly rounds if there was a gap of 2 and a bit hours. And I say every time, I want to be where this paramedic services, this ambulance services getting there in 20 minutes.
I was about to say, Caroline picked that up. This is 20 minutes, 999. Good ambulance response. So there's some positive bit there.
There we go. Positive.
Main good care for the home. Yep.
Yeah, other thing that good from the care home perspective is obviously they noticed that the leg was shortened and she was in pain, so they didn't move her. But yeah, there's a gap in that time. So how long has Betty actually been on the floor for? Has she been on the floor for 10 minutes, 5 minutes, or has she been on the floor over 2 hours?
Yeah, I think Anthony said, well, she could have been there on the floor for about 1.5 hours. Who knows?
And
where was special assessment?
It can take as little as 30 minutes, if in some circumstances even less than that, for pressure damage to happen. So bear that in mind as well. But yeah, there's nice to see that some positives have been picked up.
I think a couple of people actually pick up the 20-minute response time from the answer. I think Leslie Hunt said 20 minutes is good for a C3 response. Now, a couple of people mentioned about a sensor mat. So that seems to be a common thread here. Yep, no sensor mat. Where is a sensor mat? So I think it's something that is common in practice out there. So
yeah, there's a sensor mat. Obviously, it says that she was independent with her frame, though, and they'd had no issue. So what's their risk assessment showing? We don't know that yet. And it did say that she had a buzzer at 4 a.m. So yeah, there is things in place. Maybe it was deemed that Betty didn't need the sensor mats at that time.
Somebody said on top of the emotion sensor could be effective in Betty's case, apart from the sensor mat again. Risk assessment, in view of Betty's needs to add on to the sensor mat sort of conversation. It's about risk assessment of the need of that. She could be in the floor to 4 a.m., pop in the head in and check every hourly. That's hopefully, but I think sadly that did not happen. Okay, are we ready for the next poll, please, Ben?
Ready for the poll?
Let's see it. Right, please answer the poll. Poll's coming up. Should the care home have accepted Betty back? Oh, no. Good question. Should the care home have accepted
somebody said this earlier,
Betty
didn't
back?
they? We said let's put a pin in it. 2 weeks,
Yes.
didn't we?
So answer yes, no, don't know, or need to be assessed before returning back to the care home. Let's have a look. Yep. Let's go, guys. Fantastic. You're doing well so far. We need over 100 at least. We're about 106 now, Kirsty. 90% said needed to be assessed before returning back. 100, and it just keeps running away from me. It's so busy. So 2% said yes. 4% said no. But yeah, a majority, 89%, Kirsty, it's about 115 of them felt that needs to be assessed before returning back to the care home.
Yeah, most care homes, depending on what has happened and the nature for the admission, will reassess. And I've been involved in them reassessments when I worked in the acute services. Yes, it feels annoying that you feel like it's blocking a discharge when a patient's ready to go home, but they have their due diligence that they need to do. So risk assessments are usually done. So we'll head to
Yep. Just before you move on, guys, I just like to pick up one of the comments from the chat that somebody has said, in the absence of discharge letter, phone the hospital. I think somebody mentioned phone the hospital, have a conversation and get a handover.
I agree. Yeah, exactly. exactly. So there are things that the care home could have done as well. It's not all falling on the acute. Look for the positives and see both sides of the story. Right, let's move on to part 4.
Fantastic. Yep. Keep the comments coming. Well done, guys.
Now, I want to talk to you about when Betty came out of hospital. What was she like when she came back to the home?
She wasn't mobilizing, so we had to hoist her onto the bed. And she had a dressing on her bottom that was dirty and soiled in places.
Did you receive a discharge letter?
No, there was no discharge letter. I contacted the hospital ward to get information.
Was she sent home with any medication? Was there any information regarding this from the hospital?
No, nothing. After speaking to the hospital, we found out that she was on the same medication she was on prior to her admission. So we had everything here.
So Betty just arrived in an ambulance from the hospital?
Yes.
As you had no information, what did you do?
We rang the district nurses, who said it would be Wednesday or Thursday before somebody could visit to assess Betty, as they had no availability for extra visits.
Did you tell them how bad the ulcer was on Betty's bottom?
No. At this stage, all we knew was that she had a dressing on her bottom that needed assessing and changing. We are only a residential home, so we can't do those things.
How did you cope with Betty's needs?
With difficulty. We're not qualified nurses. We are a care home who rely on the local district nurses for nursing support. We didn't have all the relevant equipment ready for Betty when they sent her home.
What did you do?
Betty needed nursing care. So I rang the district nurses again. We couldn't wait. We didn't have any dressings available, and Betty's dressing really needed changing.
Did you speak with anyone?
I left an answer machine message. The district nurse did phone back the following day. But in the meantime, we put her back on her own medication and put on a dressing from another resident, as we had to make her clean and comfortable. We also gave her a good wash, as she looked dirty, and cut her fingernails, which had grown so long and were dirty underneath. What Betty liked best of all was a good cup of tea. She was so thrilled to see us, as we were faces that she knew. She was a lovely lady, and we loved talking to her. A bit confused at times, but we loved having her around.
What happened with Betty over the next few days?
The district nurse called to see her and was appalled at the state she was in. She'd never seen anything like it and didn't know how the hospital could send her out like that. We are only a care home, but we were just left to cope. The GP also called after 2 days and prescribed some antibiotics. The district nurse changed the dressing, but poor Betty was so poorly she just went downhill.
What do you mean she went downhill?
She seemed to lose the will to live, stopped eating, would still drink, but she lost her spark. Betty's wounds started to smell, which upset her, and she wasn't able to get in and out of bed herself, and would ring the bell if she needed the toilet, but would sometimes soil herself before we got there. It was painful for Betty to move and sit up in bed due to the pressure ulcer, and then she developed a chesty cough, so we rang the GP. She begged us and the GP not to send her back to that hospital. And John, her son, asked if we would keep her at the home and care for her there. Although we're only a care home, we couldn't send her back to that hospital. Sadly, Betty died a few days later. We cared for her and were with her when she passed on. She seemed to be at peace.
I have no further questions at this time. Can I ask Mr. Puck, representing the hospital, if he has any questions?
Right.
So, Rommel, has that caused any stir in the chat?
Yes, I'm struggling to cope, actually. They've been really, really good. I'm just going to outline what I pick up for you, Kirstie.
I told you they're keyboard warriors.
I know I'd like to get your comments in here. And I think, somebody's mentioning about an MDT meeting should have been done, that Betty's sort of care needs have changed, different placement would be required. And I think a couple of people were like mortified to start with about the GP. The GP being contacted and didn't actually see the patient. I thought, where's the GP? I didn't actually see the patient to start with. And I think from a governance perspective, somebody was quite shocked about using another residence of dressing. I've stopped there, but yeah, it's still coming. But let me know your thoughts.
Yeah, so obviously I'll pick up the dressing things. That was the last comment said. So yeah, there was no dressing sent with her on discharge. The dressing needed changing. One of the, if they're a care home rather than nursing home, have they done that aseptically? Have they done it cleanly? How have they actually done that dressing change? And using another resident's dressing, it might not have been the right dressing for Betty. And if she's got a category 4, like is being said, does it go back to what Rommel was telling you before the break about, managing the extra day, managing the gap? Was it we need the right dressings to help facilitate wound healing? Obviously they rang the district nurse, but they didn't stipulate why they needed the district nurse in a rush. They just was a bit like, well, yeah, we'll take it. The GP not going out happens more often than people probably would care to believe. Yeah. Should the care home have accepted her back? Should they have sent her back to hospital sooner? I think you're kind of gathering what they should have done there.
They are still going, Kirstie. But I think one comment earlier from Amy that I'd like to pick up is she just felt that this is a very sad case for everybody involved. Really, is how she felt about it. They are in the residential home. GP did not intervene. A lot of pressure on the home. Hospital discharge team. I think somebody mentioned earlier about this hospital discharge liaison team. Where are they? But yes,
does the hospital have one? Like, well, not everywhere is lucky enough to have. A lot of them roles, unfortunately, were redeployed during COVID, and I know of some of them that never went back. So does the hospital even have that facility and that service?
Shall we? What's the next bit? Are we? Is the poll?
Yep, over to the poll for part 4, and then we're on to the final
Ben.
video, and then they need to give us their verdict.
So, if there is a message left for a visit requesting urgent help, what should the DN team have done? If there is a message left, go on, Kirstie.
No, I was just going to say, what should they have done?
Yes, visit 2 to 3 days, visit the next day, telephone the care home for more information, or nothing. So if there is a message left for a visit requesting urgent help to the district nurses, what should have they done? Visit in 2 to 3 days, visit the next day, telephone the care home for more information, or nothing. So if it is an urgent visit required or message, for district nurses input, what should have they done?
We may have some district nurses that are with us today that might say what they do. Well.
Okay, right, let's have a look. So far 108 responded. 92% telephone the care home for more information. So majority of them visit the next day, 7%. So that's good. If you've got the capacity, that's fantastic as well. So, but yeah, the overwhelming majority, Kirstie, 114 is telephone the care home for more information.
Yeah, telephone, definitely. Sometimes when these phone calls are being made to district nurses and not being picked up by clinical members of the team, there could be admin support that aren't clinically trained. So yeah, it should be passed on and more information should be gathered to see whether or not, I mean, in this situation, Betty, capacity dependent, because I know that everyone's really busy, should have potentially been seen and assessed by district nurses that day, if not the next day. So yeah, we'll understand everyone's capacity, but if that further information would have been received and given, that judgment and that decision could have been made.
Okay, right.
Yeah. So last
yeah.
and final part of the Coroners Court simulation. After this, we will see what you're going with as your verdict.
Thank you, Mum. Betty had a fall at your home, did she not?
Yes, she had a fall, tried to get to her commode.
Did she not need nursing care to help her to the toilet?
No, for the last 5 years, she had been going to the toilet independently and would only use the commode at night, so she didn't have to walk too far soon after waking. All of our residents have quarterly risk assessments as standard, unless their needs change drastically in that time.
The nurse on the ward rang your home and you said you were prepared to accept Betty back.
But she didn't tell us that she had a huge pressure ulcer. She didn't tell us that she'd lost her mobility. She just said that she'd had her surgery, was fit for discharge, and asked if we were prepared to accept her back. We always take our residents back.
No more questions.
Mr. Smith, do you have any questions?
Yes, thank you. Can I just make it clear there was no discharge letter?
No, there wasn't.
Called the district nurses?
Yes, 2 or 3 times.
Called the GP?
Yes, with the district nurses when they visited due to their concerns.
Can you just explain to the learned coroner what type of patients you take?
We are a residential home, and all of our residents are assessed prior to coming in on their ability to perform normal activities. Most of our residents can mobilize with a frame or at least transfer themselves. We have 1 or 2 who require a hoist, but as long as they don't have nursing needs, we can accept them. If they do need nursing care, we work in partnership with the district nurses, and as long as they are happy and can support, we are also happy.
Do you have any qualified nurses?
No, sir, we do not.
No more questions.
Thank you, Mr. White. I now have a short statement to read from the family. John and the rest of the family would like to express their gratitude to all at Boot Hill Residential Home for all they did for his mother, Betty. They were very pleased you were able to keep her there and care for her, surrounded by people she knew and trusted in her last few weeks of life. Can I now ask Nurse Spears to come to the stand? Can you please confirm your name and current employment?
I'm Nurse Spears, a district nurse.
Have you been to Boot Hill Residential Home before?
Yes. We visit twice a week to provide a service for patients that require nursing care, such as catheter maintenance, insulin injections, change leg ulcer dressings.
Did you get notification from the hospital about Betty?
Yes. A message was left on our answer machine informing us that Betty had been discharged.
What information were you given?
Just that Betty had been discharged and that we would need to assess her.
Did the residential home ring you?
Yes, one of the carers left a message for us asking for urgent help.
Then why did you say you'd go in 2 to 3 days?
The care home didn't indicate why it was urgent on the phone, nor did we receive an urgent referral from them.
Did you get a second phone call?
Yes.
What did you find when you got to the home?
I was so shocked. I haven't seen anything like it for years. It was a huge sacral pressure ulcer. You could see the bone.
How would you grade it?
Category 4. We call them categories now.
Was the wound infected?
Yes. It was showing all the clinical signs of infection. We spoke to the GP who visited and said she needed antibiotics.
Think she was fit to come back to the residential home?
Not at all.
Why not?
Betty would have been fine to have been discharged with the appropriate discharge plan in place. That would have given everyone enough time to have provided the appropriate resources, such as mattresses, appropriate dressings, and support for the home, so that Betty could be safely discharged back into their care.
Why did you not readmit her?
I cannot admit someone to hospital. I have to do that via the GP. The family and Betty didn't want her to go back into hospital, though. They were adamant. The residential home were happy to keep her with our support.
Did you arrange for some dressings?
Yes.
And who was going to change them?
One of our district nursing team was to call every day.
They call every day? Did you not hear my question?
Unfortunately, no. The district nurse did not call every day.
Why not?
Well, One weekend, I left a message on the handover phone for the weekend team to visit, but no one picked it up, so she didn't get a visit on that Saturday.
Did Betty's pressure ulcers start to heal?
No,
Why do you think it didn't get any better?
it was so bad when she came back to the home. Due to her reduced mobility, she had grown incontinent. Her skin was so delicate, and her general condition deteriorated very rapidly.
This is a residential home.
Yes,
Did you arrange for a pressure-relieving mattress?
we advised regular turning initially.
That was not the question I asked you.
It was on order,
Did it arrive?
not before she died.
Who should have ordered this so that it would have been there in time?
If the hospital had given us enough notice, we could have had all of this in place ready for discharge.
Did you receive a discharge letter?
No, it actually arrived 2 weeks after Betty had died.
Was a referral made to anyone else?
No,
Why not?
I would have expected the hospital to have done that.
But surely, as the district nurse, wouldn't you request it?
Well, no. The hospital requests the district nursing team to visit. I would have requested them to have asked for the TVN referral if I had been aware of the situation.
Thank you. Mr. Park, do you have any questions for the witness?
Yes, thank you. When did you receive the hospital message about Betty's discharge?
As it was after 4 p.m, we didn't pick it up until the following morning. It didn't mention that Betty was ill or that she needed an urgent visit, just that she had been discharged from the ward and that we would need to make an assessment.
Do you see many pressure ulcers in the community?
We see a few pressure ulcers from time to time, but over the years that has greatly improved through education and training, especially in residential and nursing homes.
Thank you. No more questions.
Thank you. Mr. Smith, do you have any further questions?
Yes, thank you. Can I clarify that the residential home rang you and asked for an urgent visit and it was your decision not to do so?
Yes,
Can I also clarify that you called the GP and that he had already been called by the residential home?
yes,
Can I clarify that you did not receive the discharge letter, nor did the residential home?
yes, that's right.
Thank you. No more questions.
Thank you.
Right, Kirsty. It's still, yeah, the chat's still going, but I think they're starting to reflect now in terms of potentially what could there be the conclusion of verdict. But I'm picking up so poor system communication. I think the use of SBAR to use for appropriate referral. Betty should have been sent back to hospital. Escalation to TVN. So those are the common themes that I pick up from the chat.
Yeah.
Go
Yeah.
on.
So you got There obviously hasn't been an escalation process in place. That's very, very clear. Yeah, she obviously doesn't fit the residential home needs, which is what they were trying to reiterate, wasn't it?
Yes. Yeah.
Yeah. Yeah. Any positives?
Again, tough crowd.
I'm trying to look through the chat as well.
And I think let me provide some positive context to this then, because I haven't picked it up. But I think I think the letter from the son, from John. So he made the effort to the coroner to say that, and actually, I think from John's perspective, I'm assuming that he's supporting the residential home. So he made the conscious effort to write that letter, that he was happy with the care that Betty received whilst Betty was under the care of the residential home. So I'd like to think
to go in with this lot and be by the negative. Obviously, previously in the videos, it said that John and obviously Betty had refused for them to go back to the hospital. But was John and the family aware of why she shouldn't have been in the residential home in the first place? Why her needs had changed?
That we don't know.
How we felt.
But that's a very good question. I think that, we talked about earlier, but I think Carolyn, asked the questions about, how to explore non-concordance. But again, in this case, they haven't explored the potential consequence of I guess to
Definitely.
Betty staying at the residential home with John. I think, yeah, that's my take on it. What's your
I
take?
know it's a residential home. They said we always take our residents back, but you know, we've got to think there's the person in the middle of this, that we need to think what's best for them, and what's best for Betty in this situation was to be in a different care setting, unfortunately.
I think they picked up on that one because there's quite a lot of conversation here around what is the trainings of in place for care home staff. Really, I think somebody was asking, and somebody
It's a
kindly, I think Amy.
Postcode
Yeah.
lottery. Yeah, it is a postcode lottery, unfortunately. Some get more training and education than others, and I think it also depends on if it's a private care home or if it's part of a wider network of care homes as well. So just from my personal experience.
They are
But the
still
other thing
going.
as well is the just, you know, playing devil's advocate, the residential home manager said the nurse didn't tell them about the changes in mobility and the pressure ulcer. But did they ask? Did the care home ask?
Should have they asked, or should it be offered to them? Really? Yeah. So they're still going, Kirsty, and I
I
can see
know they're
sometimes
very.
I
I
am
told
sorry,
you.
but we are over time. So what do you want to do? Do you want to launch the poll to see what the verdict for?
Yeah.
The
We launched the
crowd?
poll. Yeah, we've got a couple of hands up as well, I've noticed. So while we've got the poll going on, I'll allow it for the two with hands up to ask questions if they want.
Hello.
Hi. So we've got yeah.
Hi. So my concern would be more so around the time that they were saying that the wound was becoming really, really bad, that Betty was declining quite quickly, refusing food, so on and so forth. Were the family informed about the severity of her condition and what the likely outcome was, and that she should really ideally go back to the acute? If she got a respect document in place and it said a DNA, do not resuscitate, this is a condition that can be rectified. So you need to do all you can to preserve that life when it's possible, and I feel as though that was not done. I don't think the family were informed about the severity of it, and that if they'd have known, they would have possibly made the decision for her to then go into the hospital. But then that's another area, whereas you could go right back to the beginning and say, why wasn't the handover more effective? Why didn't the nurse or the member of staff that was taking the handover from the hospital ask more questions about this? Wasn't there an S-bar in place for them? So there's a lot of missed opportunities going on here. But my concern is at the major point that this lady is critical, nobody had actually said she has to go into hospital. It is a reversible cause.
Yeah, and that could be down to an educational element and from the residential home. It could be that the family haven't been involved with them conversations with the GP and the district nursing that maybe do have that level. There is 19 days from discharge to death, and it's also like we don't know what level of infection was present in the wound on discharge. We know that the wrong dressing was put on, she was incontinent, so there's a lot of things but like you said, was this articulated to the family so that an informed decision could be made? The other thing, and we're going more down a legal route here, is did the family have a power of attorney to be able to make decisions about her care? So if they did know, could they have actually done anything about it, or would they've had to sit back and unfortunately let Betty make the decisions about her care herself? We don't know what was in place on that side of things. But again, best interest, capacity, all that can play into that one as well. But it's a really good point to have made and raised.
Well,
so I did disable one of the person's mic for them to come on if they want to chat.
See, let me see whether. No, I can't seem to unmute the participant.
Mic is enabled, so they have to unmute themselves.
Okay. Right, so it might not be, but so far in the poll, because they neglect 75%, narrative 18%. So 106 responded. So we still got 239
So while we're
in the
waiting
room.
for a couple of others, we might answer a couple of the comments that have gone in the chat. Like, did anyone speak to Betty? Do we know what's gone on there? Depends on finance. Yeah, if you've got social services involved, things like that, that does play a part into education. It is very sad, and I'm glad that there's lessons that everyone's gonna take away. District nurses, yeah, they should make decisions about care, but ultimately it will be up to the GP to readmit, or for the residential home to obviously ring 999, get her readmitted back through A&E, which if the pressure ulcer was as bad as what it was and her chest had deteriorated as well, that's maybe what should have been done there. What else have we got? A lot of people saying neglect. Rebecca McDougall's narrative on multiple factors, gaps in care, neglect. Failures from everybody, neglect. Another narrative there. Got another narrative from a team lead or whatever that is. Yeah, so over to you, Rommel. What do you think? Multiple areas of concern.
I think overall, as I said, in terms of looking at the verdict, I think we're all passionate clinicians in terms of how we deliver care, so we all have the intention to deliver the best. So when we see elements of gap in practice, it's so easy just to say, yeah, there's some neglect here. Prior to even doing the poll for the final verdict, I can already see the theme of the language used in terms of neglect. But and I think in this instance, there's some positive elements to it in terms of Betty's sort of journey in theatre, the impression certainly from the next of kin. So I'd like to think that the basic care has been delivered, and but yeah, absolutely acknowledge the gaps in practice. For those of you guys who delivered a narrative conclusion, yeah, there's significant gaps in practice here that you pointed out.
Yeah, so like you say, gaps in care, neglect, though basic care was given, her basic needs were met. So can you go down neglect route? But narrative, regulation 28, a given.
Yes. And I think that is the sort of the final verdict, isn't it? So from a regulation 28, I think particularly to the residential home, I think that definitely warrants a regulation 28 to avoid future death. So when we talk about process in terms of acceptance of patient from the acute setting, they were just more than happy to accept Betty.
Yeah, I think there might be some regulation 28 going to the district nurses as well in regards to how they handle it. Like Betty was supposed to have daily dressings, but it was handed over on an answer phone rather than written into a care plan, and not escalate into TVNs because it was assumed that the district nurses might receive some regulation 28s as well. Acute might survive a regulation 28 because they've already put the measures in place, which Mr. Park quite clearly often liked to answer and give his response to. So yeah,
fantastic.
Quite a lot of people are asking for copies of the slides. We will have recording, a copy of the recording from today's session will be made available, but the slides won't be sent out. And yes, you will get a certificate as well with that, along with the pathway that Rommel shared earlier in the session. If there's any more questions, if you pop them in the chat, we realise that we're over time, so thank you everybody. It's because you have all been really engaged and chatty and with the session, so that's fabulous. Trying to see, the chat is just too quick. It just keeps going back down to the beginning. If the hospital's on system 1 and all doctor surgery, would we be able to see each other's notes? That's the problem with them, and I know it's something that me and Rommel are passionate about. Not all the systems speak to each other. So hospitals don't tend to use system one, they tend to use their own system, which then doesn't speak, or there's a delay in the two speaking. If we had a universal system, it would be amazing, but unfortunately we don't have that.
Oh,
This
I
is
can
why we
see
rely on
positive.
for a
I can see positive comments now because sorry I interrupted you there, but yeah,
No, it's okay.
brilliant session apparently. So thank you, thank
Positives on
you.
us, Rommel, not the
Yes.
situation for Betty.
But really, thank you guys for your participation and for attending our webinars.
I think I've just seen another comment. I think it was from Anna. I want to say, no, sorry, Amita. If you've got if you've got 5 nurses logged in there with you, or and this goes for anybody else, if there's more than just you that is sitting in the session, if you could put their email address and their names in the chat so we can get certificates to everybody.
All right. So thank you very much, guys, and enjoy your afternoon.
Thank you,
Bye now.
everybody.
Bye.